Hi folks, welcome back. We're going to talk about the development of the immune system, some hypersensitivities, and HIV, which I inserted. It's not really a big part of your book. The pictures I use to talk about it aren't in your book, but of course I think it's very important. You'll see why in a second. All right, so immune system development. First of all, when a fetus has not started developing any adaptive immune response, we say they are not immunocompetent. So then, as soon as they start developing adaptive immune responses and start making antibodies, we say that they have immunocompetence. And it's about 3 to 4 months before a fetus can produce IgM. And yes, I know they start vaccinating babies as soon as they're born, but I'm not sure why. I think probably because at 3 or 4 months, you were able to measure a titer of IgM and maybe even some IgG. But I bet you they're making them before that. It's just that they have to be a certain level before you can see it clinically, so before you can measure it. So there's got to be some evidence-based practice out there for vaccinating newborns. So anyway, about 3 to 4 months, babies will start producing IgM, and you'll see IgG shortly thereafter. And then they're really not at adult levels of immunocompetence until right before puberty. So you're talking ages of 10 to 13, someplace in there. They'll hit adult levels of antibodies and say memory cells and things like that. So what happens before they're born? Well, before they're born, IgG can cross the placenta. So mom's IgG that can fight off different infections can cross the placenta and help protect the baby. That this is a passive immunity. The baby's not making the antibody themselves. And then, of course, after they're born, if the mom breastfeeds, which is seems to be very important, they're giving increased weight to breastfeeding. The IgA in the mom's breast milk can passively provide protection for the baby. And they're seeing more and more that how important that is, and doctors are pushing that. So that's the fetus and babies and when they become immunocompetent. Now, there are 4 types of hypersensitivity reactions. Sometimes it's not the pathogen that makes you sick. Sometimes it's your overreaction to the pathogen that makes you sick. If you didn't overreact to it, you'd be fine. But we overreact to it. We have 4 basic classes of hypersensitivity reactions: type 1, 2, 3, and 4. And you can see the other names for them. You can see immediate hypersensitivity, type 1, cytotoxic hypersensitivity, type 2, immune complex disorders, type 3, and delayed hypersensitivity, type 4. So let's start talking about them. Type 1 is your basic allergy. It's called an anaphylactic reaction because it can lead to anaphylactic shock. This is your bee sting, this is your pollen, this is your whatever you're allergic to. This whatever color that is to you, is your allergen or antigen. It's a foreign antigen. We typically call it an allergen, like it's the bee's venom or whatever it is. And it binds the IgE. This is an IgE now on mast cells. And when the allergen binds the IgE on mast cells, they degranulate. All of these chemicals inside the granules are histamines and probably some bradykinin and things like that. Remember the prostaglandins, histamines, and kinins we talked about with inflammation? Well, that's what these chemicals are. Predominantly histamine, but there's some other mediators in there as well. So the mast cell degranulates when IgE binds the allergen. This is an anaphylactic reaction. How do we treat it? Antihistamines, for obvious reasons, antihistamines, and epinephrine, the EpiPen. Now that doesn't act where you're looking right here, but remember what histamine does. Vasodilates, makes leaky capillaries. What does epinephrine do? Vasoconstriction. So the antihistamine acts against the histamine directly, and the vasoconstriction counteracts the shock because this is an anaphylactic shock producing reaction. And it's the shock that kills you, not the allergen and not even the histamine directly, but it's the shock that kills you from the histamine. Type 1 right there, your allergies. This is also type 1. It's showing you the allergen binding the IgD in this case. Yes, so look at this. It actually backed up. It backed up once and says, how come the first time you got stung by the bee, you didn't blow up like a balloon? How come the first time you were exposed to whatever you're allergic to now, you didn't react? And here's why. The first time you were exposed to this allergen, you sensitized that B cell. And that B cell had to differentiate into a plasma cell and make a whole bunch of IgEs. These are IgEs. And these IgEs had to go over and sit on a mast cell and wait for the second time for you to be exposed to the allergen. So the first time you didn't degranulate a bunch of histamine, you didn't degranulate a mast cell and get a bunch of histamine. The first time you sensitized the B cell to make a whole lot of IgE, which now binds to Fc receptors on the mast cell and is ready for the second time. And then here's your subsequent exposures. When the IgEs are there, the allergen binds, you degranulate, you get a whole bunch of histamines, leukotrienes, and other mediators. And that's your anaphylactic reaction. All right, type 2 is cytotoxic. This would be a incorrect blood transfusion. This could be hemolytic disease of the newborn. So let's use hemolytic disease of the newborn because we talked about it once before. Let's use it again to talk about type 2 cytotoxic reactions. First of all, it's when you have an Rh negative mom. Here's the mom that's Rh negative. The dad has to be Rh positive for the baby to be Rh positive. If the dad's Rh negative and the mom's Rh negative, then the baby's Rh negative, no problem. Now what happens is this. Some of the red blood cells from the baby leak into the mom's system. These Rh positive cells are in the mom's system. Mom sees those as foreign, and she builds anti-D or Rh positive antibodies. If you recall, the Rh antigen is actually called D. So this is an anti-D antibody. And remember, what I mean by D is Rh. Now, the first time the mom's pregnant with an Rh positive baby, she might not build these fast enough to attack that baby. But the second time she becomes pregnant with an Rh positive baby, the memory cells are there. And she's exposed to Rh positive blood. She makes a whole bunch of anti-D antibodies. And they're IgG. These are IgG antibodies. They cross the placenta and they hurt the fetus. So this is hemolytic disease of the newborn, sometimes called erythroblastosis fetalis. All right. This is showing you another type 2 cytotoxic reaction, and we talked about this. This is drug-induced autoimmune thrombocytopenic purpura. So this is a drug like penicillin, say, or maybe another antibiotic, and it adsorbs to the platelets. Now, the penicillin by itself is not attacked by antibodies. It's a hapten. It's not antigenic. And of course, we don't attack our own platelets because they're self. But when we see the foreign drug adsorbed onto the platelet, we see that as foreign and we make antibodies against it and they attack it. They activate complement, which puts a hole in the platelet and makes it lyse. Now we have no platelets. So what happens? We bleed and we get purple spots on our skin called purpura. It's because they're little bruises or petechiae that are little bleeds underneath our skin from our capillaries. So this is a drug-induced autoimmune because you are attacking yourself, but only because of the drug, but it's still drug-induced autoimmune thrombocytopenia purpura. Thrombocytopenia means low platelets. By the way, this could be drug-induced autoimmune hemolytic anemia if you were attacking a red blood cell. It could very well be that. This is type 3 and it's an immune complex reaction. What happens is you get these great big precipitated immune complexes that deposit into our capillary wall. In this case, it's showing you probably the kidney. It's not even saying that. It could be the glomerulus capillaries. The kidney capillaries called glomeruli. That's a lot of times where they go. It could be the synovial membrane in your joints, by the way. That's another place they go. But it's showing you the big immune complex depositing into our capillary wall. And when that happens, the neutrophils, remember what antibodies do? They opsonize the antigen and they tag it for destruction, and these antibodies increase the efficiency of phagocytosis. So now the neutrophils come over here and they begin to phagocytosize, but this is a huge immune complex. They might not be able to fit it in there. But no problem. Neutrophils are also good at extracellular killing. That means they can release enzymes that kill extracellularly. And these neutrophils release these enzymes right here, and they go down and kill our own capillary endothelial cells. Now, if this happens in the kidneys, glomerulus, you get glomerular nephritis. If it happens in the synovial membrane of your joints, you get rheumatoid arthritis. If it happens in the capillaries, if it happens in the walls of your heart, you can get endocarditis. So this type 3 immune complex reaction is seen in what we call rheumatic fever, which, by the way, are the three things I just mentioned. It's endocarditis, it's rheumatoid arthritis, and it's glomerular nephritis. And it's type 3 hypersensitivity. It's when you deposit big immune complexes into your endothelial membranes. And by the way, there's tests in the lab for this. One of the tests is called a rheumatoid factor. Another test could be called, it's just a kind of a generic test for autoimmunity called an anti-nuclear antibody, ANAs. We can test like that. So we have different tests in the lab we can use to test for this. All right, type 4 is your delayed type hypersensitivity. This is a T cytotoxic cell. This is not an antibody-driven hypersensitivity. It's a T cell, and it's called delayed type hypersensitivity because you have to sensitize the T cells. So poison ivy, poison oak, other contact dermatitis things are examples. Let's look at poison ivy. First of all, the oil on poison ivy has the resin on poison ivy has some molecules in it called pentadecacatechol. If I can think of the other name for them, I'll put it up here. It's not coming to me right now. It's kind of like at the tip of my tongue. If I think of it, I'll tell you. Pentadecacatechol molecules by themselves don't activate T cytotoxic cells at all. But what happens is they bind your skin proteins, some of your keratin molecules. And this is in fact why some people react to poison ivy and some don't. Because you have to have the right shape of keratin right here. Now, is keratin keratin? Well, yeah, kind of, pretty much. Pretty much keratin is keratin, but there's different types of keratin. And certain individuals make different types of keratin. So some people won't bind the pentadecacatechol, and some people will. Urushiol. Maybe it's urushiol. I'm thinking the name of it is something similar like that, urushiol. I think I spelled it wrong though. It's close to that, but it's not exactly that. I wish I would have looked it up. Anyway, when the pentadecacatechol binds your keratin, this then is what activates your T cells. These bind the T cells and sensitize them. All right. And what happens is you get some memory cells made. As you can see right there, you get some memory cells made. And the next time you get into the poison ivy patch, now you have many active T cytotoxic cells which go up and attack your skin because that's where the poison ivy is. Leaves of 3, let it be. See leaves of 3 right here? Leaves of 3, let it be. This is called contact dermatitis. It's a classic example of type 4 cell mediated delayed type hypersensitivity. All right, this is the extra stuff. HIV gets into our cells using a CD4 receptor. Now, who has a CD4 receptor? Well, T helpers have a CD4 receptor. All right. By the way, some macrophages have a CD4 receptor as well. So HIV affects our T helpers. Now remember what T helpers do. T helpers activate the cell-mediated immunity, the T cytotoxics, and they activate the B cells, which make antibodies. So if HIV kills a T helper cell, it's affecting both branches of our adaptive immunity. And this is what makes HIV so catastrophic, because it's affecting the link or the hub between two branches. Now, not only does HIV bind the CD4 receptor, but it also binds this other receptor here. And that other receptor could be one of a couple different flavors, a couple different types. One is called the CCR5. And by the way, that just stands for cysteine, arginine, and something else at the fifth position. Or it could be CXCR4, which just stands for cysteine, anything, cysteine, arginine. I don't know why the 4 is right there. 2, 3, 4. Arginine at the 4th position. This is 3. Yeah, the numbers are confusing me right now. But anyway, the C stands for cysteine, the C stands for cysteine. They're amino acids. The R stands for arginine. Over here, the C is cysteine, the X is anything. The C is cysteine, the R is arginine again. These are co-receptors for HIV infection. You have to have these receptors for the HIV to get inside your cells. This is showing you HIV has 2 life cycles. One is when its nucleic acid incorporates into R nucleic acid, and that's called a provirus. This can stay this way. Well, it stays this way permanently, but it doesn't come out for 12 years. It can actually hide for 12 years. When it does come out, the provirus still stays there, but you copy that information to make new viruses. And now you're making new viruses and you have the active infection. You can stay latent for 12 years, and then you can have the active infection after 12 years. Okay, now this is showing you the active infection on the bottom, and it's showing you, so here's the active infection on the bottom, and it's showing you're making all kinds of new viruses that are bursting out and infecting other cells. Now this graph is great. This shows you,
AIDS is caused by the...
Okay, sorry about that. This shows you, let's talk about the black line is the viral load. The black line is how much virions are in your blood. The red line here is your T helper population. So when you're first infected, your viral load skyrockets because the HIV virus is in the lytic stage. It's making new viruses. And your CD helper cells plummet because you're killing T helper cells. However, you have other ways to fight off viruses. You make antibodies against them, all right? So then the virus starts feeling some pressure from the antibodies, and they go into the proviral state, and they stay there, and they hide. And so now my viral load plummets, and it goes way down. Why? Because now I've fought off all of the active virions, all the active HIV viruses. They've gone into the proviral state inside my T helper cells. And I've cleared all the active viruses. However, during this proviral state right here, different cells are infected, and they won't do it all together. They'll be all asynchronous. They will go into the lytic state and kill a T helper, and then feel the pressure of the antibodies and go back into the proviral state. But slowly over time, they're killing T helpers, and my T helper level is dropping. About 8 years later on this graph, remember that it can be up to 12 years that it does this. About 8 years later on this graph, my T helper hits a critical threshold level, where below this, the T helpers are really ineffective at activating either my humoral immunity or my cell-mediated immunity. And that critical level happens to be 200 per microliter. A cubic millimeter is a microliter. So just remember that. That's 200 T helpers per microliter, or a cubic millimeter is a microliter. Now, back in the day, before we could count T helper cells, because we have the instrumentation that counts them now. So back in the day, we used to diagnose AIDS with some classic diseases like Kaposi sarcoma, or pneumocystis. Oh, I can't spell sarcoma. Pneumocystis carinii infection, or Candida albicans, a simple yeast infection that hurts us because we're immunosuppressed. Pneumocystis carinii. So anyway, I'm not going to put them all up there, but I'll put one more. Candida albicans. Yeah, there I go. There I go. I'm spelling like a champ. Candida albicans is just a simple yeast infection, thrush, but it wouldn't hurt anyone that's immunocompetent, but it hurts you when you're immunocompromised. We used to diagnose AIDS with some classic diseases, but now we can count CD4 cells, and that's how we diagnose AIDS. If your CD4 count falls below 200 per microliter, you have clinical AIDS. That's when they diagnose you, say you have clinical AIDS. So this is the graph that shows that the HIV virus can hide, and this graph shows it's hiding for 8 years, but it could be up to 12 years, just so you know. So you can see that here.
The human immunodeficiency virus, HIV. This is an enveloped virus. The envelope is derived from the host cell membrane with viral glycoproteins such as GP120 and GP41 inserted into the membrane as the virus leaves the cell. The core is composed of P24 capsid protein, and the P17 matrix protein helps maintain viral structure. Inside the core are 2 identical copies of single-stranded RNA viral genome and 3 enzymes, reverse transcriptase, RT, protease, PR, and integrase, IN. To establish infection, HIV must first attach to its host cell. Attachment occurs by interaction between GP120 on the surface of the virus and the CD4 antigen receptor on the surface of the host cell. In addition to the CD4 receptor, there must also be a co-receptor on the host cell. The co-receptor differs for different host cell types. In T lymphocytes, the co-receptor is called CXCR4, whereas on macrophages, the co-receptor is called CCR5. After attachment, the viral envelope and host cell membrane fuse, resulting in entry of the virus into the cell. Once the RNA is released into the cytoplasm of the host cell, reverse transcriptase makes a DNA copy of the viral RNA genome. As the DNA is being formed, reverse transcriptase degrades the RNA strand. A complementary DNA strand is then added by the reverse transcriptase, and the ends of the resulting double-stranded DNA segment are joined non-covalently. Treatment with nucleoside analogs or reverse transcriptase inhibitors interferes with these steps. The resulting circular DNA is then moved to the nucleus and inserted into the host cell chromosome by the viral integrase, IN, enzyme. The integrated viral DNA is now referred to as proviral DNA. Following integration, the proviral DNA may remain dormant, or with host cell activation, RNA may be synthesized from the DNA, yielding messenger RNA and viral genome RNA. Viral messenger RNA is translated, yielding viral enzymes and structural proteins. Some of the functional proteins are formed by cleavage of a long polyprotein by the enzyme protease. Protease inhibitors interfere with this step. GP41 and GP120 are inserted into the host cell membrane, and the structural proteins surround the viral RNA to form the core. Finally, the virion is released by budding.
Okay, that's the life cycle of HIV. All right, what about the effects of aging on the immune system? Well, first of all, when you're born, you have a large thymus gland, and as you get older, that atrophies. But it's still there for quite a long time in your life, even though it's atrophied and quite small. And you make a hormone called thymosin, but when you get elderly, you quit making that thymosin. So now you're not going to turn on the bone marrow production of your lymphocytes as much because the thymosin is lacking. So you have fewer and fewer lymphocytes as you get older. And what that does is it removes your ability to fight off cancer, because what T cytotoxics do, and by the way, remember, natural killer cells are lymphocytes, so you're also diminishing your natural killers. What natural killers and T cytotoxics do is they go around and they survey for viral infected cells and they kill them. They survey for abnormal cancer cells that make abnormal proteins on the surface and they kill them. But now you're not making thymosin, thymopoietin, you're not making it. So what happens is you don't make your T cytotoxics and natural killers, and you get cancer. So that's one of the big things of aging. There's an old saying all the time. I've heard it from several different people, several different professors in my life. If you don't die of something else first, you're gonna get cancer. Now, I mean, you could say that about lots of things, but if you think about it, it makes sense. You can't like you can't say, well, if you don't die of something else first, you're gonna die of a hangnail. Probably not, right? So if you don't get hit by a bus and you don't have a heart attack and something else that is pretty deadly doesn't happen to you and you live long enough, you're going to get cancer. That's what they say. Now, here's the good news, and this is just me speculating, but I think cancer is going to be cured in your lifetime because we're making leaps and bounds on that disease or those diseases, because really every individual cancer is a separate disease. Although you could look at them all as one disease depending how you look at it. So we quit making thymic hormones, so our immune system drops. Our immune system is attenuated or weakened. And this is showing you a system integrator with how the lymph system, the immune system reacts with other things. All right, folks, I'll see you in the respiratory